Namaste. My name is Dr. Roopesh N. I am a senior consultant gynecologic oncosurgeon, peritoneal surface oncology specialist, and Laparoscopic surgeon. My main area of interest is in gynecological cancers, in which I have been extensively trained from across the country, like Tata Memorial Hospital, Amrita Institute of Medical Sciences, Kochi, and other international centers like National University Hospital, Singapore, National Cancer Institute, Milan, etc. So I deal with gynecological cancers, which are nothing but cancers related to the female reproductive tract. That is, cancer of the cervix, cancers of the ovary, or cancers of the inner lining of the uterus called as the endometrial, or cancers of the muscular portion of the uterus, which is called as uterine sarcomas, cancer of vulva, cancer of vagina, and fallopian tube cancers. So these are the group of gynecological cancers. So now we have a specialized training only for these cancers, management of these cancers, in which I was fortunate to have been trained. And of this, the most important cancer, which has been the main cancer that in our country, especially in the rural women, has been cervical cancer. So cervical cancer is a preventable cancer. That's the only preventable cancer because it is caused by a virus called as human papilloma virus. So we also have a vaccination against cervical cancer, and cervical cancer can be prevented by simple testing called as pap smear testing or HPV DNA testing. So with regards to cervical cancer, it usually is seen, as I told already, in the rural women because of multiple reasons, because of early marriage, because of multiple sexual partners, then poor genital hygiene, usage of tobacco, and frequent childbirths. So these are the various risk factors for cervical cancer. And in cervical cancer, predominantly, as I told, it is because it is caused due to virus. It is largely preventable by screening the woman. So in fact, cervical cancer is the only cancer which is a preventable cancer entirely. In fact, we are looking towards the eradication of cervical cancer. And after diagnosis by a simple test called as pap smear or cervical biopsy, we classify the patient into which stage they belong to. If they require any additional imaging like MRI, we do an MRI, and after that, based on that, we take a call whether the patient can be treated by surgical or by other modalities such as radiation. So in most of the cervical cancers are a little advanced stage and locally advanced. So that is the reason many of them are treatable easily by radiation and chemotherapy. Whereas there are some cancers seen especially in earlier, younger age women which can be salvaged by a surgery. So there are various modalities for that. So likewise for ovarian cancer, when we come to ovarian cancer is one cancer which is exactly the opposite of cervical cancer because it is not made out in the early stages. 75 to 80% of ovarian cancers present in advanced stages. That is the reason ovarian cancer is called as the silent killer. In fact, the 10 to 20% are the only number of cancers which present in early stages, which are detected incidentally, which are kind of diagnosed accidentally for some other reasons. But majority of them present only when they are advanced, especially in stage 3 and stage 4 cancers. So ovarian cancer is one which is, as I told you, the silent killer. The main modalities of treatment for ovarian cancer is surgery and chemotherapy. So surgery involves performing radical surgeries like ultra radical surgeries, wherein we open the abdomen and we remove the tumor, the entire tumor deposits, whatever is visible to the naked eye, we remove that. And this has been the traditional surgery that we have been doing for ovarian cancer. But of late, there have been advancement in ovarian cancer such as hyperthermic intraperitoneal chemotherapy, or called as HIPEC, wherein we heat the chemotherapy to a certain degrees, certain higher temperature, and then we circulate it after doing the surgery for ovarian cancer, that is the cytoreductive surgery, that is removal of all the macroscopic disease. Then we instill the chemotherapy, we heat it up, we heat the peritoneum, we heat all the microscopic tumor cells which have escaped the onslaught of the surgery. They are killed by this HIPEC, and such patients are the ones in whom we recently have had evidence of higher survivals or better survivals. So that is one of the modalities. But all said, such cancers still have a tendency to relapse. So we have newer modalities such as PIPAC, which is pressurized intraperitoneal aerosolized chemotherapy, which is a modality wherein we convert the liquid form of the chemotherapy to an aerosolized form and we circulate it through a laparoscopic approach within the abdominal cavity, and we try to shrink down the extensive tumor metastasis. So this also has been proven to improve the quality of life of many of the patients who are relapsed and who do not have much of medical line of management left for them, that is chemotherapies, who have already exhausted many lines of chemotherapies. So like this, there are variety of newer modalities of therapies available for gynecological cancers and even for endometrial cancer. I am speaking only of the 3 top cancers in gynecologic malignancies. So I spoke about cervical cancer, ovarian cancer, now is endometrial cancer. Endometrial cancer is on the rise now because it's more of a lifestyle associated cancer, wherein we see such cancers in obese women who are diabetic, who are hypertensive, or any of these combinations. So these are the women in whom we see endometrial cancer. And also of late, we see many women conceiving late, many women planning for pregnancy at a later age in their lives. And these are the ones who are also at high risk of developing endometrial cancers. And there are a set of, I'm sure many of you would have heard about PCOD, that is polycystic ovarian disease. So these are also another subset of people who have a higher risk of developing endometrial cancer. So endometrial cancers again are still, compared to the other 2 cancers, endometrial cancers are one of the best because they are usually diagnosed in a very, very early stage, usually in stage 1. And whenever they are diagnosed, we have, a surgical management is enough to cure the disease, to completely conquer the cancer. And we also do something called as sentinel lymph nodes, wherein we do not try to remove the entire lymph nodes, we only just remove the involved nodes. So these are all the various newer modalities of treatment which I have shared with you. And apart from this, mainly the most important thing for a gynecological cancer is that the appropriate diagnosis at the time of visit, the patient's first visit, that is most important. Appropriate choice of imaging, be it MRI or CT or PET-CT or whatever, or the combination of it. Then appropriate planning of treatment. What is the most relevant or most appropriate treatment for this particular patient, which we usually take a discussion of, in an MDT meeting, it's multidisciplinary team meetings. Sometimes for difficult cases, for complex cases, this is what we do. For straightforward cases, we generally go ahead with the prescribed form of treatment. So that is most important. And over a period of time, not just doing the surgery or the radiation per se, but also the follow-up. How do we follow them up? And how do we ensure the quality of their life? That is most important, because a woman is the central pillar of any house. And when a woman is affected with cancer, the entire house gets devastated. So in that context, the follow-ups, the correct diagnosis, the proper treatment, this ensure a better quality of life for that woman, and eventually it improves the quality of life of the entire family. So this is one of the most important things, and we see we encounter in gynecological oncology, and we deal with such cases. And not just that, now of late there are something called as fertility sparing surgeries, which is also one of my areas of interest. Fertility sparing surgeries are those surgeries which we do in women who are afflicted with cancer, but we still tend to preserve the organ for fertility. Say, for example, a young lady who's still not conceived, who's planning to conceive, having kids, has been unfortunately diagnosed with cancer. So if she falls into the appropriate categories, we will try to strategize and see to it that if you are able to retain some portion of our ovary, then yes, we will retain. Or if you are able to retain the uterus, yes, we will retain. So these are fertility sparing surgeries or fertility sparing procedures that we do for cancers in young women. So these are the gamut of, just a brief gamut of the conditions which I have explained to you. There are still lots of things that we need to understand about gynecological cancers, because as I always keep telling, woman is the most important component of any family across the globe, and so that woman has to be protected. So So for all women who are ignorant, most of our women, the problem is the rural women are ignorant about their health. The urban women are so busy in their life that they neglect their health. So this is the point wherein we have to reach out to women telling that no, your life matters. Please have a yearly screening with pap smear or a HPV DNA testing once in 3 years, or also have a screening mammogram after 40 years every year. And if at all there are any kind of complaints, any menstrual issues, anything bothersome, any kind of gastrointestinal problems, so please, especially if you have gastrointestinal problems and if you have been found out to have some ovarian mass or ovarian cyst, do not neglect them just like anything. Please consult your gynecologic oncologist so that you will get the most appropriate way of how the condition is to be managed and dealt with accordingly, and the complete treatment is ensured. Thank you.